textbooks, dermatology, primary care. Throughout our lives, we will all interact with the healthcare system. So, what happens when that system is not designed with certain groups of people in mind? As a Black person in America, I have experienced firsthand racial disparities in healthcare. The turning point for me came during the pandemic when at a local clinic, I was asked if I had a red rash on my skin. At that point, it dawned on me that some healthcare professionals did not realize that skin rashes do not exhibit the same way on different skin pigmentations. If something so obvious could be so casually overlooked by a healthcare professional, what other elements of care, treatment, research, and education are also being ignored, and what does it mean for people of color using this healthcare system? I am Vivian Kopsinger-Birchall, and in this series, we will take a closer look at racial disparities in healthcare, speaking with medical professionals, and hearing personal stories to get a better understanding of those disparities and explore ideas and strategies for how to bridge the gaps. I'm Vivian Kopsinger-Birchall, your host. My guest is Dr. Wilfred Ngwa, a professor at Harvard Medical School and clinical researcher at Brigham and Women's Hospital and Dana-Farber Cancer Center, and he will tell us more about his work at those institutions in a little bit. So we will be talking about healthcare disparities, especially among the Black people. But before we get into it, skin color is a significant aspect of our lives because it clearly sets our identities apart. It is something that cannot be changed. However, in many ways, skin shapes our human relations almost in all parts of the world. And over the years, people with darker skin pigmentation have faced numerous unpleasant experiences. And today, we'll focus on the impact of this skin color on the quality of healthcare and also in integrating in and being a part of healthcare processes. With that, I would like to say, Dr. Ngwa, welcome to the show.
Thank you very much, Vivian.
What is your profession exactly, and what are other details about yourself that our viewers can know about before we dive into healthcare disparities?
Yeah, so I'm a professor at Harvard Medical School, like you said. I actually also I'm also a researcher, scientist. So as a professor in radiation oncology, so my work is really focused on treating cancer. 50% of cancer patients are treated with radiation therapy. So my job in the clinic, I actually have a job as applying physics in the clinic to ensure that the radiotherapy is delivered safely and effectively to cancer patients. And then I also do research to make sure that we can make treatments more accessible and convenient for including. So being a director, I'm also a director of the Global Health Catalyst. The focus really is to bridge disparities, which is a really important focus of your program. And so really excited because some of the technologies we've developed in the research are actually meant to increase access to care. And I'm going to share a little bit about that.
And how long have you been into this profession of yours?
Yes, so I've been at Harvard for 10 years. Before that, I was at MD Anderson Cancer Center. It's one of the best cancer centers in the world. And that's where I kind of started my training transition. My background was, I was born in Cameroon, but then I did my graduate studies in Germany. And then when I was in Germany, most of the work that I did was in physics. If you know Einstein, when you think about physics, right? And then when I came to the United States, I decided to transition into applications in medicine. And so I'm very excited about some of the work that we've done, in this area, developing some of the work that we've done, developing, tiny drones to target cancer, which I've shared with you in your program before. Also won a number of awards. Actually, just last week, we won another award, the best in physics award in the United States.
Congratulations.
Yes, for applying this technology to for cancer patients, treatment for cancer patients. So
Thank you for that introduction. And earlier in the introduction, you talked about your Global Health Catalyst program and its aim at bridging the disparities. In your experience, what are some of these disparities in the healthcare for people, especially for people with dark skin?
shocking. Where can I start? I mean, actually, recently I wrote a paper. The Lancet invited me to write a paper in the Lancet journal. It's one of the best journals in the world, in the Lancet Oncology, and it was for Black History Month. And so I talked about, really nice. The article, let me first congratulate you on the article to the Harvard Crimson, the
Thank
color
you.
of medicine, the color of medicine. That's a really powerful article. I think a lot of people need to read that. But it was kind of a similar article in the sense that, but focused only on oncology. The title essentially, we kind of started by just saying being Black is bad for your health currently. Okay, so it really means that having the dark skin is already a risk factor just because you're Black. And let me give you some statistics to show that. So in the United States, Black populations have an overall higher death rate from cancer. And just give you examples, Black men die 3 times more mortality than whites and other populations for prostate cancer, 3 times. Okay. And then for women with breast cancer, 50%, if you're above the age of 50% more deaths for Black people compared to white populations. So we are in the same country, but just because you're Black, right, you get to die at a faster rate, at a higher rate than other populations. So that you can basically say being Black is bad for your health. And so the big question is, how can we eliminate that, so that just because of your skin color, you don't have to die because you have cancer more.
What are some of the reasons that, the statistics are the way they are? Why is it that we die in the Black person dies at that scale?
Yeah, so it's a great question. There are multiple factors and sometimes a little complex. One of it is really historical. It starts from the slave trade, right? So slavery, the structural racism that's always been there means that, if you're Black, you're going to live currently in a poorer neighborhood, you are less educated. A lot of studies have been done here at Harvard and other places that basically show you that your zip code, if you live if you're poor, you're likely to die more because you don't have access to healthcare. You can afford it. Obama did a little bit of good with the Affordable Care Act, definitely helped increase access to healthcare. But nowadays in the United States, when you have cancer, when you're diagnosed with cancer, for example, sometimes you have to think about your finances first before you think about going to the doctor. It's more a consideration for you is whether you can afford the payment. And so for poorer folk, who have been disadvantaged, because of structural racism, that's a big problem. And then there are also factors, like I mentioned, educational factors. Let me just tell you that, if 15% of the United States population, or 13% to be more accurate, about 40 million, like you mentioned in your article, are Black, right? But if you think about how many people are in my field in oncology, 3%, right? That's atrocious number. So it means that if you actually have cancer and you went to a clinic, you're likely not going to see somebody who represents you in that clinic. And that's why, they may not. So a lot of the system is developed in a way that the experience in your healthcare that you get is not that good because you're Black. And so, so education, historically, economic factors, there are also cultural factors. Okay, so you may have heard about the Tuskegee Experiment, where Black men were, Black people were exposed to syphilis and then they were not given the treatment. So that has really made a lot of Black people very skeptical about participation in healthcare or clinical trials. until today, talking about COVID-19 today, I have friends who are still suffering from vaccine hesitancy because of that. If you ask them, they tell you that that's the reason. Uh, okay, but let me also just focus on oncology, since that's really my strength or background. You may have heard about Henrietta Lack. He was a 31-year-old woman, Black woman, who went to Johns Hopkins University Hospital in the January 1951. He went to the hospital because she was poor. Johns Hopkins University Hospital was one of the hospitals that was able to give care to poor people. And so when she arrived, she said she complained about bleeding, vaginal bleeding. She was a mother of 5, and so she complained about that. And then the doctor went to look at that. The surgeon went to look at that and saw that she had cervical cancer. That was a large mass that had started, that was causing the bleeding. And then the doctor went ahead and took out some samples from that cancer and gave it to his colleague, who was an expert, as a really great scientist and working on cancer. But the doctor did not tell Henrietta about that, or the family about the fact that he had given that tissue sample to this colleague. And so over the years, so this colleague went to his lab and found out that the cancer cells from this woman could continue to multiply and grow, even when other cancer cells from other cancer cells she'd been trying to grow were not growing. These ones were multiplying, doubling in every 24 hours, and they have a name. He named those cells HeLa cells after the name Henrietta Lack. So HeLa cells, those cells, those are the cells that have, scientists have used over the years, just basically granted immortality to their woman. Over the years, scientists, including me, have done studies on those cells. Polio vaccine was developed because of studies on those cells. A lot of studies, even including COVID-19 studies, have been done on those cells. And we have done some of the work that I've done with the tiny drones developing here at Harvard have been with those cells. But here's the problem with that. The problem was not giving those cells. It was just that she didn't even know, and they didn't recognize her. You may have seen Oprah. There was a movie that came out about that, about her. And nowadays, people are, so the ethics was not correct. Obviously they are now correcting for that. The United States President Clinton did apologize for the Tuskegee Experiment. Nowadays NIH, they are doing a lot to kind of recognize Henrietta Lack for this, and so. But that problem has not gone away. I just want to say this story because it's historical, but it's still here, which means that, a lot of Black people, the statistics are stunning. A lot of Black people, even when they contribute to science or do stuff, they actually innovate more than whites. It's a study that came out in the Proceedings of the National Academy of Sciences, but they get very little recognition for what they do. And you don't find them in leadership positions or they don't get. So that creates that structural systemic racism is still there in such a way that it's very difficult to get their contributions translated to science. And they have this cultural hesitancy, the treatments and stuff like that. So I'm actually working really hard on this because we're starting some clinical trials on our technology this summer. And, we definitely want, people are excited about it. I actually see more Black people interested to take, because they're looking at me and saying, yeah, that's also, definitely a Black person cannot be trying to harm me, that kind of thing. So it's good to see that, that's possible. So we're gradually moving, but it's still there. So just to summarize, there's historical reasons. There are, educational reasons. You remember during the slave period, people could not go to school. And nowadays I have students who, don't have role models. Their parents never went to school, so they don't care about going to school. And then you also have economic factors, you have cultural factors, and all of this. And I think, it really needs to be fixed.
Well, there is a lot that I want to unpack from your statement. You've touched on so many things. One is 3% of oncologists that are dark skinned. you know, the question to that would be, how can that be fixed? And
Yes.
the second one is, you talk about, you know, the people, the students you're training,
Yes.
uh, that will, you know, which would takes me to the question about what kind of training, what kind of textbooks do you have,
Mm.
research journals, and how have they influenced your professional knowledge and approach to treatment and care?
Yeah.
Let's start there.
Yeah. Actually, that's a really, very important question because, also in the Lancet article, I did talk about that. Let me just step back and talk about go back to history and just can give you the background for why how the solution here is. So, in 1860 something, in the 1860s, when slavery was abolished, so Abraham Lincoln basically worked hand in hand with a gentleman called Frederick Douglass, African American, to be able to fight alongside gallantly. They really fought. That recruited a lot of Black people, a large Black contingent to fight alongside white populations to stop slavery, to abolish that. That was very successful then because of that enlistment of Black people to participate. They actually formed an office of colored troops in Washington to be able to get additional recruitments. So because Douglass was there, because Lincoln worked with Douglass, it was easy to then recruit because the confidence was there. The Black population was able to come along and fight. Okay, so fast forward today, we can use the same approach. Which really means that you need to recruit a large contingent of Black people, to be involved in addressing health disparities. It's not only in oncology. We know that's going to happen in any other fields, where we see, a lot of disparities across different things, heart disease, whatever, HIV, AIDS, COVID-19 is a good example, latest example, right? So, but just going back to the oncology example, so basically you have to recruit a lot of Black people to be, just like was done during the American Civil War, recognizing, number one, that there's racism, systemic racism in healthcare. There's the color of medicine, like you rightly said in your article. And so being Black is bad for your health, and saying that you have to abolish that, like you abolish slave trade. To abolish or eliminate that, you need to have a large contingent of Black folk participating in that. And so you have to create a pipeline. So the recommendation essentially here is that, each institutions have to, first of all, recognize that big need for that. I should say that President Biden and Kamala Harris have set a very good tone, in being able to recognize that there's systemic racism and, and so looking to address that. But each institutions need to do that too. You have to recruit a lot of people, Black folk, to be participating in healthcare. We'll have to raise that number from 3%. That should be the milestone. Should we go 3% to at least 13%? It has to be proportional to the population of the United States. If there are 40 million people, Blacks in the United States, 13% of the population, any institution that does not have 13% of Black people in any of those areas has not met their goal. It cannot be 3%. So, and that doesn't mean it's going to happen like just today. Remember that there's this structural racism that's already there. And so you have to create a pipeline starting from high school, from even kindergarten, like you have to start from there with that daily. So it means that you have a 10-year plan, obviously a short-term plan and a long-term plan. And so, it means that you have to reinvest into that. So this is not just a policy issue. You have to actually invest money into it, recruiting, Black doctors and oncologists and researchers, creating scholarships for supporting training and stuff like that. You can call it reparations. Reparations have become very toxic in some sense. Some people really support that, but some people have used that negatively. But the reparation really here is saying, let's right this wrong that's in the system. Let's create more opportunities where we can have role models and have other Frederick Douglasses, who can fight alongside white folk to be able to abolish this.
Thank you. Going back again to the training, your training when you were studying all this, this is something I highlight in my article, which you've referenced, a few times, that people don't recognize some dermatological conditions
Yeah.
in Black people. And my question to you, as somebody who has studied medicine, or
Mhm.
what was that training like? What were the textbooks like? What is the field like when you're writing research journals?
Yeah.
Just
Yeah,
curious.
so most of the textbooks right now are still written by whites. I mean, I have been blessed to. I've actually written 3 books now. And one of the books is really on bridging disparities. But if you want to go to real medical textbooks, like in radiation oncology and all of that, I think that we need to have. That's why if you recruit more Black folk into the field, right? They can then be the leaders who can write textbooks that take into account your skin color or your cultural background or all of that stuff. It really has to be there. Like you have to have, those Black professors, 13% of them in any institution, or reflect the community in which you live. You really have to have that reflection. And so yeah, so that training it just means that you have to train more people who can then and recruit them into those positions. And obviously they're going to write textbooks that reflect the color of their skin.
Excellent. And going back again to some of the interventions, your work primarily is to try and bridge these healthcare gaps
Yes.
through your innovation and creativity. And you have developed tiny drones and other research. Can you tell us more about these different projects that you have and how they are aimed at bridging these gaps?
Yes, I'm very excited about that. One of them, the tiny drones to target cancer, it's really thanks to Brigham and Women's Hospital. They've really been investing a lot in this. They have this Bright Futures Prize. They've been investing a lot in actually bridging disparities more recently. But this technology is really focused on why? Because one of the factors I mentioned to you was that there's the economic factors in access to care. So what happens like in cancer treatment, in radiation oncology where I work, like I mentioned, this is used to treat over 50% of cancer patients. The cost, if you have prostate cancer, I'm going to go back to the example. For most Black folk, they cannot afford the treatment or access to that. And what that means is that, when they start thinking about the money, they are also going to come present late with a disease, which means that they always come when the cancer has already spread to other parts of their body, when it's very difficult then to treat. And so the technology we developed was to address specifically that. If you have cancer that has spread to other parts of your body, how can you treat that? And, immunotherapy won a Nobel Prize in 2017, but you can already see a lot of disparities in that. Like, you need a lot of money to even get access to an immunotherapy. In most zip codes in the United States, you will not even afford that. And right now, only a few percentage of the population benefit from that. And so the technology we developed was really to make that more accessible. So let me give you an example. We actually published a study just this past year that shows that the cost that somebody would need, it would save, over 50% of the cost if you use this technology to treat prostate cancer, for example. And the time it would take to treat, one patient, you can treat 7 people with the same when you use this technology. And what that really means is that for people can afford it, they can have access to it, and in low resource settings, where people may not, be able to have access to treatment, more people can actually get treated. And it's going to be a huge deal, especially in increasing affordability and making sure that they have quality care, especially for the metastasis, which is responsible for 90% of cancer patient deaths. Because African Americans and other people who are poor backgrounds, they usually present late with the disease and the cancer has spread. You have to develop interventions that really work for them. If you don't, then you're going to keep the margin of 3 to 1 mortality, 3 times more likely people to die of prostate cancer than other populations, different from Black. So the great news about it is that, now we are working with the FDA already. We already have these planned clinical trials for the summer. we're going to have multiple institutions, involved in this, including Johns Hopkins University, the Dana-Farber, Mayo Clinic, and all of those. So that's going to be really excellent. We're very excited about the possibility, and then we're also going to go across the world. So we actually have centers. Oxford University is a collaborator, and then we have my friend there, Dr. David Kerr, who I should encourage you to interview. He calls me the Black Panther in cancer because he thinks that, the technology, nanotechnology, which is part of the technology, is actually Wakanda technology. If you watch Black Panther, you may have seen that's one of the technologies they have. The suits that Black Panther wears, it's made of nanotechnology. It's actually better than what Iron Man wears. So we've actually leveraged that technology in treating cancer. And so yeah, you should.
It's not just fiction.
Yeah, it's not fiction. We're actually bringing it to reality. Yeah. Wakanda forever,
Wakanda forever.
Yes.
Yeah. So my question about that, I mean, we've talked about the disparities, and some people argue that they exist because Black people do not want to participate in clinical trials.
Yeah.
And I know that you have clinical trials coming up. Mm-hmm. What is going to be your strategy on making sure that the Black people are represented?
Yeah, number one, Vivian. So basically going back to what you had asking about textbooks, number one, you want to have, just like the question there was really, if you have a Black person write a textbook, he's going to take into account the skin color, and you will not face what you faced when you went, and they're asking you, do you have red skin or something like that? In our case, you need to have Black folk leading the clinical trial. You also have to have Black people who are leading the clinical trial. So actually we know studies show that when a patient walks into the clinic and sees that the provider is of their same skin color, the experience is much better, right? So it's easier for me to talk to my friends and say, like when I took my COVID shot, it was easier for me to tell other people who are Black to take the COVID shot because they've seen that I've taken it and I'm okay, and I'm encouraging them to do that. So that's the same thing. That's the great thing about the clinical trial. We're going to involve, leaders, oncologists who are Black as well, as few as they are, and then also the other thing is that we're actually going to be partnering with a lot of churches. Part of the things that, the cultural, so some people actually faith-based organizations can really help. So we're going to have multiple intervention levels here, where, for just a mental health component, we've seen that it's holistic. Even when you have cancer, it's not just a physical treatment, there's a spiritual and mental component of it. And so we're going to be partnering with communities, which can also encourage participation in this. Just like for COVID, we're going to be dealing with the same kind of thing that people have been dealing with COVID. And so very excited about it. I'm looking forward to coming back sometime and sharing that with you,
Absolutely. It's always a thrill to get some updates from you.
Yes.
Speaking of updates, one of the other interventions is you're working on a project about a plant that has been found to have higher
in Wakanda.
Exactly, in Cameroon, Wakanda, that has been found to have higher hemoglobin than the human blood. Mm-hmm. How is this in research and medical breakthrough potentially going to bridge healthcare gaps in communities of color?
Yeah, as you know, I mean, that's a big. I'm also excited about that. It's actually called that plant the herb. If you also watch the Black Panther movie, you have these this herb that's there that actually gives the Black Panther his superhero abilities. So we found this plant that unbelievable can also power your blood essentially because it has a hemoglobin. Hemoglobin is what helps get oxygen when you breathe. Binds oxygen and then takes that to your body and gives you the energy that you need, right? So usually, you wouldn't think that plants should have hemoglobin. They don't need that, right? But remarkably, we found out that in this plant, it actually has higher. So we've published some study on this already, where we kind of showed that, and again, kudos to Brigham and Women's Hospital. They've definitely supported a lot of this work. We're able to show that, it has more hemoglobin than what you have actually in the humans. And so, we've moved this to the level where now the technology is ready for clinical translation. So now we are just working to finalize since COVID disrupted a lot of things last year. We're already at a point where a lot of investment and excitement, including also in Africa, so the Wakanda itself. So basically thinking about how they can use that. So to your question, how can that increase access? So it turns out that, anemia is one of the big killers. It affects like 1/3 of the world's population. 1 out of every 3 people, and especially women, are anemic. And so, and most of these populations in low and middle income countries and also Black populations do not have access readily to this. You can get iron supplements now. But if you have chronic anemia and you have, or when you want to have constant access to this medication, it's not always affordable. So going back to affordability, that's something that we think can help in bridging disparities, because we want to make sure that this is accessible. In Wakanda, it will be free, like we've talked about the patents and stuff like that. Even though there's a patent involved here for the United States, it's going to be mostly for the United States, but we want to make sure that the foundations that can subsidize that and increase access. So one of the applications will be anemia, but we also look at application for blood transfusion. So basically you develop something that has, it's blood group neutral. So it means that, even the US military, in 2018, when we actually had a presentation at Brigham and Women's, I think you were there. So we have a NASA interest in this. Person was looking at, this is something you can use as we're thinking about going to space, right? You're going to want to get blood available to you, or the US military in the war front. So we have it in such a way that you can just have a powder, and then when you need the blood, you can just add water to that. You can get blood right away. You can transfuse that. And then one other application, which I always talk about, is the environmental impact of that, right? So, we've been able to show that, as developing burgers that have, or foods that have, instead of taking, meat, cow meat, or, that has hemoglobin in it, you can actually manufacture burgers. So Bill Gates has invested a lot of money in companies here beyond meat. If you go to Dunkin' Donuts, you may find some of these foods. But these are using GMO, genetic modified foods. So this is a good opportunity where we can actually bring something, directly naturally from, and it's going to create a lot of economic benefits as well, as people cultivate this and create plantations and stuff like that. So, long live the cows, like we always say, because in that case, you don't need cow meat. You can just, use this to prepare burgers. People can eat them and they'll have the same deliciousness that you get from, cow meat. So that's going to save emissions. So 40% for those who, actually I gave a presentation about this somewhere, and, one of the environmental people ran after me and say, you're my hero, this is the future, because actually meat cultivation is like 40% of carbon emissions, emissions that have contaminated the environment. And so up to 40%. So if you can actually move towards, not reducing the consumption of meats, that can actually save the footprint, the environmental footprint. So going green, yeah. So that's, people are excited about that. In fact, that's why they go to Dunkin' Donuts and buy Beyond Meat, because for some of them, that's their own way to say we keep the environment healthy. So
interesting to bring in the environmental conservation aspect about it. But let's take a step back about this particular plant. One would argue that the American institutions are stealing from Africa, and how is it really going to benefit the Black person in Africa in a way that is affordable?
Yeah, so we actually had language that shows that, for the African populations, the patent would not, will relax the patent for that. So that's one way. We also want to work with in different countries, like in Cameroon, for example, those communities so we've actually set up like a foundation that, some of the profits that come out of this will go to subsidize healthcare in those locations. And also here in the United States, we want to be able to support. That's one of the things, like I mentioned, economic factors are a big driver of disparities, huge driver. So if you can have some of these resources to support minorities, Black people to get access to care, from those communities. That's going to be a huge benefit for those countries. So yeah, so even though the patent is here in the United States, we want to make sure that the populations also benefit. That's not going to stop them from having access to it. That was actually part of the the discussion and language going into this.
I will personally hold you. You can believe that.
Yeah. No, I'm with you. I know you are a big advocate for that.
Yes, which is closely related. We've seen many medical breakthroughs that have originated from indigenous plants in Africa, and they have been heavily patented by the West. What can we do to advocate for some of these patents to be relaxed for the good of the people in our communities in Africa, or Black communities in general?
Yeah, I mean, we need to keep speaking out like you're speaking out. I mean, clearly you are concerned about this, and this is a good, people need to hear about that. Speaking out, I would say that things have improved a little bit. It's still there, but things have improved a little bit now where, even as we think about, such developments, collaborations with Africa, it's always been that, those collaborations end up, Africa doesn't benefit from that. Very similar to the Henrietta Lacks story. Henrietta Lacks story I talked about in Johns Hopkins, right? So, we've benefited, the whole world has benefited from this woman, but, until some point in time, the family was not benefiting from that, and so, we need to make sure that keep speaking out, making sure that, people have those checks in place. I would say that most United States, funding agencies now or support, when they support collaborations with Africa, actually, if you develop a patent, as part of a collaboration, it must be shared. It must be shared. You cannot just take that by yourself. Now, that said, there are always companies who are greedy. They are going to, they're going to try to exploit all of that, and the communities there will not benefit. And so we have to keep pushing. And as to medicinal plants, yeah. I mean, we know that about up to 60 to 80% of the world's population actually depends on medicines from plants, including here in the United States. And a lot of the previous medicines, breakthroughs in medicines, have really gone through science on plants, looking at the bioactive components of that. I mean, so so that's something that Africa is actually, and most Africa is very rich in some of those things, in South America as well, and so also the Caribbeans. So recently we published an article with Jamaica on showing how they are really rich cultural, the plant diversity that they have. They're really rich in that, and that can really be a good, not just for medicine, but so you can get health and wealth from that. If you invest rightly. In the United States, you've seen cannabis. People are crazy about cannabis. That's also medicine from plants. I mean, if you get that done rightly, where you actually use that, you actually study that and use that well for the benefit of people, that can bring both health and wealth as well. So there's a huge potential in plants, plant medicine, phytomedicine.
Yeah, I guess that calls for environmental protection so that we can save plants of medicine.
Yeah, we need to grow more plants too. Yeah, we need to grow a lot. Everybody can grow, yes.
Right. So really, that is something I'm passionate about. First of all, preservation of indigenous plants, and also, trying to fund research to discover more plants out there of medicinal value that we might still not know before they get extinct.
Yeah, and I really want to partner with, you, and I know that's a big, that's something close to your heart. And as we just got some funding now from NIH to kind of move the whole idea of the disparities. So NIH is National Institute of Health in the United States. So to kind of look at how you can bridge these disparities, not just in the United States, like with these clinical trials, we're actually see how it's going to benefit a lot. I'm going to go back to Henrietta Lacks. So look, if you just look at cervical cancer, okay, cervical cancer now also still disproportionately, the highest number of deaths in the United States are Black and Latino. But guess what? That woman's cells, from cervical cancer have been used to develop all sorts of things that are benefiting the whole world, whether it's the polio vaccine or COVID-19 or all those things, right? But you still see these populations not still being disproportionately affected, this Black population. And so, we really want to, with this funding that we got now, we really want to make sure that we bridge the disparities here in the United States. But because local health is global health, I can tell you that local health is global health. If you do things, COVID-19 makes it very easy to see, because if you have COVID here and you don't address it here, it's going to go across the globe. Or if it starts from somewhere across the globe, it can come back to your community. But also, if you develop scientific breakthroughs like we're doing here in Boston at Harvard Medical School, they can benefit the whole globe, right? You can go, or if you discover something in Africa, like this blood plant from, you can benefit the whole world. So, so we really want to partner with you on this, because I think it's something that, it's close to your heart as well, as we go around going forward with this funding that we just got. It's good.
Yeah, I am certainly looking forward to working, together with you and your organizations and, with the institutions that you represent. Mm-hmm. And with that, we're just going to wrap this up for this session. And I want to end with, first of all, before I end, has there been any particular experience you've had as a person receiving healthcare, not as the researcher, not as the professor, but as a patient, that made your eyebrows, made you raise your eyebrows? I'm like, why did you do that, or ask me that?
Yeah. Yeah. So I've not experienced that in the healthcare system, even though I have family who have, have cancer and have had, I think they could have had better care. But I've experienced, a lot of systemic racism. Even where I am, in the position where I am, through different people. The system it's not a particular person, but it's the system. You can actually see that the things that are in place, the system doesn't support. It's actually oppressive, in some ways. I'll give you an example in Germany for me, it's always been, because you cannot, you have to just really be patient, and you see that the leaders are very interested in addressing that. It's very slow and frustrating, but at least that's why I was giving the example of Biden. At least you are hearing the right things. People are saying the right thing. They're putting some of their money, they're investing to that policy change. So in Germany, when I was there, I still remember, the people, the German guy was working with, basically saying, spitting at me. I mean, basically a guy in the rural, it was in the eastern part of Germany, where the Nazis were. So we still have a lot of the right, extreme, extremists who don't like foreigners, so it's like really, very vocal against me, saying, go back where you came from, and all of that and stuff like that. I was actually in a temporary job position working with the person, and I was just like, I know where I'm going at. I know the longer term. There was always the choice: do you make a big deal out of that, or do you just look at the longer term picture and say, tomorrow I'm not going to be with you. I'm going to be somewhere else. So I don't have the energy to waste to fight you at this particular point. I chose the latter in this case, because obviously some of the things the guy did, speeding at me and all of that, it was overt racism. And you face that every single day, whether it's in your, looking at the way that you're treated, in your jobs, lack of recognition. That's been different at Brigham for me, I would say. But there are other things that you see the system really against. That's why there are very few Black people in positions of leadership and being able to do those things. So I've experienced that. Sometimes I've just chosen not to talk about it because I look at the longer term picture. But it is there, and our leaders acknowledge that every single day. People are dying. COVID-19 is a good example of that, right? You see 3 to 4 times more people who are Black who are dying of that. So many complex factors involved. I personally have not suffered like you did, that having to deal with the fact that because of your skin color, people are, misappropriating the medicine to you in that sense, because they don't really recognize, they don't have the textbook or the training, which is part of the system, right? If they don't have that training, they are actually doing it unconsciously, so you can't really blame that person who had that with you, but it's just the training that they had. So we have to change that. So it's something that we'll have to keep fighting and being vocal against. That's why this series that you're doing on this is really important. If you don't speak out, people are, you have to really educate the public about this. And I should say last thing that just going back to that historical analogy, Abraham Lincoln and Frederick Douglass working together. Black people have a role to play in this. We have to continue to be determined and do what you are doing. Actually educating people and also being at the front lines. I would say, some of the work that I'm doing, I'm really excited to be a part of that in that sense. But we must collaborate with white folk, with white people and other people of other races. Collaboration is key. Just like Abraham Lincoln collaborated with Douglass to abolish slavery. If we want to abolish systemic racism, we have to work together.
Very well said, Dr. Wilfred.
Yeah.
One thing I must say is we appreciate you. We appreciate all the contribution you've made to science and you continue to make to science.
Thank you.
Not just for our country, but for the world, because it's going to really change the world.
Thank you. Yes.
And with that, thank you so much for being my guest yet again. And I look forward to hosting you again to continue highlighting not just the disparities, but the different interventions in medicine and advances in medicine, just to make this a better world.
Thank you so much, Vivian.